So thanks for inviting me. I'm happy to be here today to give you a talk on, so I was asked to talk about the ongoing clinical trials in autoimmune neuromuscular disorders. So very happy to be here. If you have questions, we said we'll get to them then, but you can ask them in French or in English, it doesn't matter. Obviously, I will introduce a little bit the main neuromuscular disorders before I talk about the clinical trials that we have here. I'll start by reviewing, in a very simple manner, the basic principles of autoimmune disorders. How do they function? Which cells are affected? And how do we treat them at the present time? And then I'll go into specific neuromuscular disorders and the current trials that we have at the MNI now. So, right. So, as you guys know, the immune system's role is mainly to prevent, to attack viruses, bacteria, to prevent foreign agents to invade the body, and to maintain normal function within the body. Unfortunately, sometimes our immune system recognizes some part of our own body as being foreign, and eventually attacks our own body, causing inflammation and damage to your own structure. So, all immune system cells are actually made in the bone marrow. So that's the marrow within your bone, which is mainly present in around in the pelvic bones, but it's also in the long bones in the body. So the bone marrow is going to secrete most of the cells of the immune system. Other parts of the body are also considered within the immune system. Some people consider the skin as a it's a physical barrier, but it's not a cellular component. So the skin is a barrier. There's the lining of the blood vessels also form a barrier. So these barriers prevent the foreign bodies of entering, but they're not active as are the cells that are made by the bone marrow. So grossly, we divide the immune system into two components. There is the general defense component, which is also called the innate immune system. So these are the cells that attack any foreign body in a non-specific manner, so general defense. And then there's a special defense or specific defense, which attack more particular cells and are much more targeted, which are also referred to as the acquired immune system. So the general defense is mainly composed of monocytes and macrophages. These two entities are grossly the same thing, monocyte macrophages, and granulocytes, or they're also called polymorphonuclear cells because they have multiple nuclei within the cells. So these are the components of the general immune system. And then often when a foreign body comes in, these are the cells that are first present at the site of the primary immune reaction. And then they secrete factors and proteins, hormones into the blood to recruit the special defense, specialized immune system cells, which are composed of mainly lymphocytes. And lymphocytes are often divided into T lymphocytes because they're formed, they get modified, they're all made in the bone marrow, but they get modified in the thymus gland. The thymus is a gland right under the neck, and that a lot of people eat. In animals, obviously. And so T lymphocytes, and then B lymphocytes. B is for blood because these B lymphocytes are circulating in the blood. So again, this is the same thing. The first cells to react to a foreign agent. Here the agent is the RSV virus, which causes bronchiolitis in kids. So when the RSV virus comes in, you get your innate immune system that gets activated with the polymorphonuclear cells, the macrophages, NKs, phenolic killer cells. These cells attack the virus, but also secrete these cytokines to recruit the acquired immune system. And the first cell is the CD4 helper. So CD4 is a marker on the T cells. So these cells come and they recruit other cells, mainly the B lymphocytes and the CD8 T lymphocytes. The B lymphocytes are very important because they secrete antibodies, and these antibodies do part of the damage to the neuromuscular system, whereas the CD8 T lymphocytes are cells that attack directly the virus or attack directly the nerve or the muscle cells. Again, this is so adaptive immunity is acquired immunity, is the same. So another drawing to tell you that B lymphocytes are here. B lymphocytes secrete antibodies, which are, so antibodies are proteins that attack the viruses or attack the components of the nervous system. Or T lymphocytes, which is also referred as cell-mediated immunity, and the T cells bind directly to the foreign agents and then lyse them by chemicals. So grossly, this is a very, very, very simple summary of how the immune system works. So how do we try to inhibit this overaction of the immune system and this wrong action of the immune system against our own neuromuscular system? So most neuromuscular disorders have the same gross principles. There's first-line drugs and then the second-line drugs. So the first-line drugs or the primary immune agents are usually steroids, IVIG, or plasmapheresis. So the way that IVIG or plasmapheresis work is obviously complicated, but to simplify, IVIG and plasmapheresis work on the B cells. IVIG tries to, IVIG is a bunch of antibodies. IG means, so IG is just because it's given intravenous, and IG is immunoglobulins. So IVIGs are a bunch of antibodies, just like those, that are pooled from multiple donors, and they're given into the blood. And these antibodies, one of their mechanisms of action is to bind the bad antibodies and to neutralize those bad antibodies. Whereas plasmapheresis is a method where you pherese the blood, meaning that you put a catheter in one vein, you take out all the blood, you pass it through a filter, and then you put it back into another catheter. And the goal of this filter is to get rid of all those bad antibodies. So both IVIG and plasmapheresis work much more on diseases that are affected by B lymphocytes and antibody secretions. Whereas steroids, they work on both sides, but they inhibit lymphocyte production in general. So they inhibit production both of B cells and of T cells. They have multiple other mechanisms of action, steroids, but grossly that's one of their main mechanisms of action. So these are the primary agents, and usually once you're diagnosed with an autoimmune neuromuscular diseases, most people are started on steroids, some people are started on IVIG or plasmapheresis, and some people are started on a combination of those. The problem is that these medications can have side effects, long-term side effects, short-term side effects, and their effect is temporary. So we need second-line drugs to try to decrease the amount of steroids we give, or to try to space out the amount of IVIG we give. And there's a lot of second-line drugs that exist, and most of them are quite toxic, so we don't like to use them. Azathioprine or Imuran and MMF, which is mycophenol mofetil, also called Cellcept. These two have similar mechanisms of action. They work on lymphocytes and they increase the production of lymphocytes. There's cyclosporin or tacrolimus, which works specifically on T lymphocytes, so specifically on the cell-mediated immunity. And then there's other drugs. So Imuran is the one we use most of the time, and the other ones are used less often because they're probably more toxic. So these are, just vague general principles. I'm going to talk about specific diseases now. As I said in the outline, I'll start by talking about CIDP, which is an autoimmune nerve disorder. Then I'll talk about myasthenia gravis and Lambert-Eaton, which are both neuromuscular junction disorder. And I'll say just a few words about muscle inflammatory disorders. So CIDP is chronic inflammatory demyelinating polyradiculoneuropathy. So the name summarizes the main clinical features. So it's chronic, meaning that the onset is usually over more than 8 weeks by definition. Very rarely it can start acutely, but most of the time it starts subacutely or slowly. So there's constant progression over more than 8 weeks. So inflammatory refers to the fact that it's probably autoimmune. Demyelinating, I'll explain that in the next slide. It means that it's a disorder that attacks the myelin, which is the fat around the nerve, and the role of the fat around the nerve is to help the nerve conduct electricity more rapidly. So since the fat around the nerve is attacked, the nerve conducts electricity much more slowly, and one of the main characteristics is a slowing of conduction velocity when we do the nerve conduction study, those electrical shocks in the EMG lab. And then finally, I just want to insist that it's a polyradiculoneuropathy and not a polyneuropathy. What does that mean? Radicular refers to nerve root, so the beginning of the nerve. So it's a disease that affects the nerve itself, it also affects the nerve root. And that's why usually you have significant weakness, but you have both proximal and distal weakness. Proximal means close to the body, distal means the hands and feet. So a typical CIDP patient would have both proximal and distal weakness, and not only distal weakness like most polyneuropathies have. It's a motor predominant disorder. Obviously, almost all CIDP patients have clear sensory symptoms and numbness, tingling, loss of sensation, but they have much more deficit because of the weakness and the motor symptoms. And you can definitely have pain with CIDP, but it's not as prominent a feature as the motor deficits in general. Again, these are general terms. There's obviously exceptions in every patient. And it's usually a symmetrical disorder. So again, there are exceptions, but usually right and left is relatively similar. So that's a general introduction on CIDP. Again, this is a nice drawing. That's a motor neuron, which is the cell body, the cell itself. And the cell is going to have an extension, which is the axon. That's the axon. It's still part of the cell. It's kind of the extension of the cell. And the axon is, multiple axons form a nerve. The cell body is located in the spinal cord. The beginning of the axon is going to be the nerve root as it comes out of the spinal cord. And then it's going to go down into the legs or into the arms, and that's going to be the nerve. And these round structures are the myelin. So myelin, as I said, is the fat around the nerve, and its role is to allow faster electrical conduction. It's basically like an isolation around electrical wires. And then the nerve is going to end with connection to the muscle. That's the muscle. So there's a connection between the nerve and the muscle, and it's called the neuromuscular junction. There's a small hole here, which is between the nerve and the muscle. It's the interface between the nerve and the muscle, and this is what's called the neuromuscular junction. So in CIDP, the pathophysiology or the pathogenesis is thought to be an immune reaction against the myelin. So these are macrophages or lymphocytes that go and attack the myelin itself and causes destruction of the myelin, which causes slowing of the conduction, which will cause the weakness and the sensory symptoms. So, like other neuromuscular disorders, the basic principles of treatment for CIDP are very similar as the other ones. So, steroids, IVIG, plasmapheresis are the first-line drugs, and all three have been clearly proven to function relatively equally for this disorder. We often start with IVIG because it's easier to administer than plasmapheresis, and because it has less long-term side effects than steroids. But all three, in theory, work just as well. And if somebody doesn't respond to IVIG, there's a possibility that he responds to steroids. So if one doesn't work, we often try the other one and then the third one. But sometimes we combine them. We should probably never combine IVIG and plasmapheresis because plasmapheresis takes out the immunoglobulins or the antibodies, whereas IVIG are antibodies, so it's a really bad idea to combine them. But we often do a combination of IVIG and steroids or plasmapheresis and steroids. So, as I said, if the first-line drugs aren't enough, we sometimes add a second-line drug, and Imuran is the one most commonly used. Some places in the States, some places in Europe use cyclophosphamide more often, especially the Dutch like cyclophosphamide. And other drugs have been tried, but they're really not used very, very, very often. I mean, it's quite rare actually that I see a patient with some of these drugs. And there's aggressive study that tried stem cell transplant for CIDP, and that seemed to be effective, but stem cell transplant is a very morbid procedure. There's a risk of dying, so we don't like to do that. It's just a very small preliminary study. So the study that we have now at the MNI is on a drug called fingolimod, or Gilenya. I don't know if any of you has heard of that drug before. It's a relatively new drug that's used in MS for maybe the last 4 years, I think, 4 or 5 years. And it's been proven to be effective in MS, so we're trying it in CIDP. And you'll see that's a common theme of my presentation. There's a lot of drugs that have been tried in MS because they have more money to try these drugs, they have a bigger population, and once it's proven to be useful in MS, we try them in neuromuscular disorders. So fingolimod or Gilenya is sphingosine 1-phosphate receptor agonist. You don't have to remember that name, I don't even know what it means. But it's basically a receptor found on lymphocytes, right? So fingolimod goes and binds on that receptor, which is on the lymphocytes, and tells the lymphocyte to stay in the lymph node. So if the lymphocyte is trapped in the lymph node, it can't go and secrete antibodies, and it can't go and attack nerve or muscle cells. So it kind of neutralizes that lymphocyte, which inhibits the immune damage. So the study is ongoing now. I think we have 3 patients on the drug. We had 3 patients on the drug. One of the big fear of patients with that study is that you have to stop your treatment, if it's whether IVIG or steroid treatment, and then go on the drug immediately. And a lot of patients are quite afraid of stopping their medication or their treatment because some of their disease often worsens. And the hope is that people on fingolimod won't worsen, whereas people on placebo are going to worsen as expected. And obviously, at the earliest sign of worsening, we stop the study and we give the patients back their medication so that they don't worsen too much. But it's still quite unpleasant to have to stop their primary medication. The study is a long-term study, up to 3 years is the maximum of the study. So of the 3 patients we had, 2 of them worsened, so we stopped the medication and we give them back their IVIG or their steroid treatment, and one of them is still ongoing, doing well. So fingolimod has some side effects which have all been described in MS patients. The first one is the scariest one. It causes severe slowing of the heart in some patients. And there's actually been reports of patients who died from severe slowing of the heart. Bradycardia means slow heart rate. But we've learned from those MS trials, so now we keep the patient in a monitored setting on a cardiac monitor for 12 hours after the first dose, and then they go home with a monitor as well for the first 24 hours. So we're very careful about that. They all get regular EKGs while they're on the medication. Lymphopenia means decreased lymphocytes. That's not surprising, right? The mode of action is to trap the lymphocytes in the lymph node. So if the lymphocytes are trapped in the lymph node, there's less lymphocytes circulating in the blood. And the other side effects are rare or not as severe. So the first two are the main ones. But in general, it's a very, very, very well tolerated drug. You know, compared to our other second-line drugs, which are more toxic, fingolimod is very well tolerated. It's just once a day, and most patients have no side effects. So we'll see if it works. All right. So moving on, I'm talking about a second neuromuscular disorder called myasthenia gravis. So myasthenia gravis is a disorder that affects the neuromuscular junction. Remember, that's the junction between the nerve and the muscle, right? The connection. This is a drawing of the neuromuscular junction. So this is the end of the nerve cell, and this is the beginning of the muscle cell. So the junction is that small space between the two. Myasthenia gravis has been recognized for a long time as the prototypical autoimmune disorder because we have identified the antibody clearly. We have clearly proven that the antibody causes the disease. It binds, the antibody binds to the acetylcholine receptors. Let's go to the drawing. So, so usually, I'll just summarize quickly how the neuromuscular junction functions. Usually you have the electrical signal that comes from the nerve. So this is all electricity. And once it comes here, there's some calcium channels at the end of the nerve. And when there's a change in the electrical signal, the calcium channel opens. So that lets calcium inside the nerve cells here. Calcium is going to bind to those vesicles and will cause the release of the vesicles in that space, in the neuromuscular junction space. So those vesicles contain acetylcholine. Acetylcholine is the protein, the compound, that goes and binds the muscle cells and causes the initiation of the contraction of the muscle cells. So, so in order for acetylcholine to bind the muscle cells, there are receptors of acetylcholine all around the muscle membrane here. Those myasthenia gravis antibodies, there are acetylcholine receptor antibodies. So they go and they attack those receptors and they prevent acetylcholine to binding to those receptors, which causes the symptoms of myasthenia. So symptoms of myasthenia, one of the main features of all neuromuscular junction disorders is fluctuating symptoms. So they're usually good in the morning and then you worsen throughout the day. Or sometimes you're good and then you're bad a few hours later and then you're good again. So that's very typical of neuromuscular junction defects and myasthenia gravis in particular. Worse at the end of the day. So all the symptoms fluctuate like this. So the symptoms are muscle weakness because the problem is that the connection between the nerve and the muscle cells. So all skeletal muscles are affected. So muscle weakness, whether the arms, the legs, the neck, some people have a head drop. But for some reason we don't quite understand, it affects even more the muscles of the eyes. So people can have one eye muscle that functions and then the other eye muscle that doesn't function as well. So one eye moves, the other eye doesn't move in a conjugate manner, and that gives you double vision. or ptosis. Ptosis means drooping of the eyelids. You can't keep myasthenia gravis patients begin the day with open eyelids and then progressively their eyelid closes and covers their eyes. Dysarthria means difficulty talking, so as the day progresses, people slur their words more and more. Dysphagia is difficulty swallowing, and sometimes you can have breathing difficulties as well. So there's a lot of treatment for myasthenia gravis. Most of the treatments are similar to other neuromuscular disorders, but we have something in addition, which is a small symptomatic treatment called pyridostigmine or mestinon. That's a molecule that inhibits an enzyme that is present at the level of the neuromuscular junction. The enzyme is called acetylcholine esterase. So, as you remember, acetylcholine are present here in the vesicle. They go back, they go down, they bind those receptors, and eventually, once they've done their job, there's an enzyme, acetylcholine esterase, that takes breaks down the acetylcholine, and mestinon inhibits that enzyme. So the acetylcholine is going to hang around much longer in that neuromuscular junction, and will have more its effect for a longer period of time. So even though there's less receptors, there's going to be more acetylcholine around, so that's going to help the symptoms of myasthenia gravis patients. So that's asymptomatic treatment, so it doesn't change the course of the disease, but it helps patients feel better. The main treatment is prednisone, so you suppress the immune system, you suppress lymphocyte production, so you have less antibodies around. In an acute setting, you want to get rid of the antibodies as quickly as possible, so you give IVIG or plasmapheresis. And then there's all the immunomodulatory drugs, like the other disorders. So the goal is to try to lower the dose of prednisone as much as possible, because if you're on prednisone for a long time, you have a lot of side effects. So those other medications are started to try to decrease the dose of prednisone. So this is the basic idea about how myasthenia gravis functions. More recently, we've understood something else, which is that with time, one of the main problems isn't simply that those receptors are blocking, those antibodies are blocking the receptors, but with time, patients with myasthenia gravis have a change in configuration of their muscle membrane. So instead of having folds like this in the muscle membrane starts to become almost flat, which leads to the fact that there's less space to have receptors, and then there's less receptors, so the acetylcholine doesn't function as well. And the mechanism of action, so how this happens, going from this to this, is caused by small proteins that are part of the immune system and that are called complement. So complement proteins bind to different receptors, and then they create a cascade of reaction where one protein binds to another protein, and eventually there's a release of inflammatory mediators, and it recruits more lymphocytes, and those folds get destroyed. So the new drug that is being studied at the present time in myasthenia is called eculizumab. Don't ask me to say that 10 times. Some people call it Soliris. That's the future trade name is Soliris. So eculizumab is an inhibitor of the complement system. So it inhibits, I think, the change in configuration. So C5 is one of the complement proteins, and then it gets divided into C5a and C5b. So eculizumab works here and inhibits that reaction, so that there's less complement around. When there's less complement around, they don't recruit as many lymphocytes, and that prevents that change in configuration. So long-term patients with myasthenia gravis are less likely to have weakness and all these fluctuations. So the study has started, and then it was stopped for a short period of time. So we're not recruiting patients as of now, but I think it's going to be active again in a few weeks. And it's a phase 2 study, meaning that the goal of the study isn't as much to see if the drug is working on. Obviously, we want to check that, but the goal of the study is to see what's the best dose that may work. So they're trying different dosages, and once they have the right dose, they will do a phase 3 study to see whether that dose is really effective. Right. So it should be starting soon. There's strict criteria. One of the criteria is that you have to have tried at least 2 or 3 immune modulating agents, so prednisone plus IVIG plus a third long-term agent like methotrexate or Cellset or Iran. So you have to have severe refractory myasthenia gravis. So you have to have failed 2 or 3 treatments before being a candidate for that study. All right. Next disorder, it's basically like the cousin of myasthenia gravis, the small cousin of myasthenia gravis, because it's much less prevalent, it's much rarer. It's called Lambert-Eaton myasthenic syndrome. It's called a myasthenic syndrome because it's another disorder of the neuromuscular junction, that connection between nerve and muscle. The main difference is that myasthenia gravis, we often call it a post-synaptic neuromuscular junction disorder, meaning that it's the problem is, so the synapse is the hole in between, the synapse is the space between the two. So post-synaptic means the problem is at the level of the muscle folds here, the muscle membrane, because it's targeting acetylcholine receptors, right? Lambert-Eaton is a presynaptic disorder, so it's at the level of the nerve cell. The problem is here at the level of the nerve cells. So like I told you, when the electrical signal comes in, the first thing that happens is an opening of calcium channels, where calcium comes in, binds to vesicles, and releases acetylcholine in the neuromuscular junction. Lambert-Eaton is a disorder where you have antibodies, like myasthenia, clear antibodies, against those calcium channels. Sorry, the calcium channels are here. This is potassium, this is calcium. So the antibodies are against the calcium channels, and you have less calcium influx, so you have less acetylcholine release. And there's been a drug, clinically, patients have similar symptoms to myasthenia, which means weakness. The difference is that the weakness involves much more prominently the legs. You can have leg weakness in myasthenia, but in Lambert-Eaton it's predominantly leg weakness. And you have much, much less eye involvement, double vision, drooping of the eyelid compared to myasthenia. And they often have autonomic dysfunction, drawing out being a big symptom. So there's a drug called 3,4-DAP. DAP is diaminoperitine. That's been known for a long time, for at least 30 years, I think. At least 30 years. Probably more, probably 50 years. But that's quite rare, the drug. There's only one company that used to produce it in the States for all of North America, and it used to be quite hard to get that drug. So 3,4-DAP, the mechanism of action is to inhibit potassium channel, not calcium channel. By inhibiting potassium channel, the small amount of calcium that's still there is going to hang around more for a longer period of time, so you're going to have more release of acetylcholine. So again, it's a symptomatic treatment. It doesn't modify the course of the disorder, because to modify the course of the disorder, you want to attack those antibodies that are attacking the calcium channel. But it's a symptomatic treatment to compensate for symptoms, so by allowing more calcium to stay for a longer period of time, you have more acetylcholine release, so patients feel better. So, as I said, the drug has been there for a very long time, and it used to be difficult to get. We used to have to call the company or write to the company. It would take several months before we would get the drug, because it wasn't approved officially by Santé Canada or by the FDA. we had to have we had to go through hoops to get the drug. It was difficult. So there's a company that decided to do a clinical trial to prove that the drug is working. And it caused quite a bit of controversy because a lot of people said, because once they did that clinical trial, it costs money. So now the drug is available, it's approved, but it's much more expensive. Before we used to be able to get it for free for patients. However, it was very difficult to get. Now it's much more available, but it's more expensive. So there was a bit of controversy in the neurological journals about how ethical the whole thing was. But the study's done now, and the results are positive, which is not surprising. We knew that this drug was working, and the drug is much more available. It's already available in Europe, and it's going to be on the market here soon. All right, I'm going to finish up very quickly with the last component of the neuromuscular system. We talked about the nerve. We talked about the nerve-muscle interface, or the neuromuscular junction. And so I'm going to finish by talking about the muscle. So a muscle disease is called myopathy. And when the muscle disease is caused by inflammation, it's called myositis. So all muscle, again, I'm exaggerating, but most muscle disorders present with proximal weakness. So so mainly arm weakness, head weakness, leg weakness. So the inflammatory muscle disorders follow the same rules. So you have proximal leg and proximal arm weakness, and usually you don't have that much of a same weakness. So dermatomyositis and polymyositis are the two main inflammatory muscle disorders. Dermatomyositis has significant skin involvement, and the pathophysiology is very different than polymyositis, but they both have significant inflammation at the level of the muscle as well. So what you have is small inflammatory, so this is a normal muscle biopsy where you have those muscle cells that are separated by a small amount of connective tissue. But here, when you have a lot of inflammation, you have all these inflammatory cells, which are monocytes, macrophages, or lymphocytes, that attack the muscle cells. They invade the muscle cells, and they cause muscle inflammation and breakdown and muscle fiber death, and that's why you have weakness. So the drug that is currently being studied, and I have to say I'm not as involved in this trial, it's Dr. O'Farrell, who's the principal investigator of this trial. It's called siponimod, which is a cousin of fingolimod. And if you remember, fingolimod is the drug that we are studying in CIDP, which binds to that receptor and inhibits lymphocytes from going out of the lymph node. So siponimod does the same thing. How is it different than fingolimod? I'm not sure, I haven't looked at that in details, but it does the same thing. Binds to the lymphocytes and prevents the lymphocytes from going outside of the lymph node. So it's a much shorter trial, it's only 12 weeks, and patients are randomized to placebo or drug treatment for 12 weeks. And if they choose to, they can all go on the drug treatment for another 12 weeks and then continue regular follow-up. The drug isn't marketed, so fingolimod is already on the market. It's used regularly for MS patients. This one is not, but it showed some positive results in phase 2 studies in MS, but it's not on the market like fingolimod. All right, so I've talked quickly of the main current neuromuscular trials that we have here at the MNI now. There's obviously other trials in other sites which I haven't covered. But I just want to emphasize a few points to finish up. So autoimmune neuromuscular disorders are all particular, but they all have a similar approach to treatment. So we have our first-line drugs, and then we have the second-line drugs to try to spare them out of the first-line drugs, and then we have symptomatic treatment. And all neuromuscular autoimmune disorders have significant or different therapeutic options, especially among the second-line drugs. And we're trying to find other drugs that aren't as toxic as the known second-line drugs that are effective. So we're just trying to add to what our current therapeutic options are. Right. Most of these trials have strict inclusion and exclusion criteria, which I haven't discussed. For instance, myasthenia, they have the myasthenia gravis patients have to have refractory myasthenia and have to have failed several other medications. The CIDP patients must have had a relapse of their CIDP within the last year. So people must have active inflammatory disease because these drugs target the inflammation. They can't do anything to repair the damage to the nerve or the muscle that was already caused by previous inflammation. So we'd love to recruit patients to these trials if they fulfill the criteria. But for patients, it's also very important to have a clear, informed consent. We usually have a nurse that discusses that we give all these potential side effects. The nurse meets with the patient, discusses the risks of participating in a trial. And at all time, patients are always free to withdraw from a trial for any reason. Patients don't have to give a specific reason. If you're fed up, if you don't want to come, no matter what, you're always free to stop. Thank you.